This eHIV review program is presented by DKB Med Radio.
So this patient is clinically in menopause because she has not had a period for more than a year. Vasomotor symptoms and early menopause or menopause before 40 are both indications for menopausal hormonal therapy. However, current evidence suggests that this therapy is seldom offered to women living with HIV. So yes, she should definitely be offered hormone therapy to help with her symptoms.
ART, HRT, pregnancy, and menopause in women living with HIV. Welcome to eHIV Review. Two of the most significant events affecting a woman's life and health are pregnancy and menopause. For clinicians caring for women living with HIV, the task of guiding their patients safely through these life-changing periods can be complicated by many questions. How might hormone replacement therapy impact family planning? Does hormone replacement therapy protect against STI transmission or acquisition? Which classes of ART might interact with hormone replacement therapy? Does living with HIV induce early menopause? What defines when a patient is appropriate for menopausal hormone therapy? To discuss these issues, we're joined today by Dr. Anna Powell, Assistant Professor of Gynecology and Obstetrics at the Johns Hopkins University School of Medicine. For our guest disclosures and additional CME information, please go to our website, ehivreview.org, and select the Volume 9, Issue 2 link. I'm Bob Busker, Managing Editor of eHIV Review. Dr. Powell, thank you for joining us today.
Thank you so much for having me here.
Our overall learning objective is to describe the safety and use of various ART regimens with hormonal contraception. Our first key learning point under that objective is many women living with HIV, WLWH, are not being counseled about contraceptive options by their HIV care providers. This represents a missed opportunity, not only for limiting unintended pregnancies, but also for minimizing the potential risk of transmission to their partners, as well as vertical transmission to their infants. So, if you would please, Dr. Powell, take us to the clinic with a patient scenario.
Sure. So we have a 23-year-old woman who was diagnosed with HIV within the last 2 years. She had a peak viral load of 150,000 copies per mil, but more recently, her viral load is 2,000 copies per mil. She's taking tenofovir alafenamide, emtricitabine, and dolutegravir. She's not currently using contraception, but is not planning a pregnancy in the immediate future. She does not have any major medical problems, and she's hesitant when we bring up the possibility of hormonal contraception.
She's hesitant about the possibility of hormonal contraception. Two quick questions, doctor. How often do you encounter this concern from women living with HIV, and why do you think that is?
Thanks, Bob. To answer your first question, I would estimate that around 1 in every 10 patients I see has some hesitation when we bring up hormonal contraception in clinic. This could be for a number of reasons, but primarily I suspect because of misinformation or possibly because of side effects they've experienced from prior hormonal contraceptive use.
How would you approach this patient? Walk us through your initial clinical encounter, if you would, please.
Yes. So first, we would take some time to discuss her sexual history and review her history of contraception use. Then we would review that with her current antiretroviral therapy medication regimen. She has no obvious contraindications to hormonal contraceptive use, and generally that we consider hormonal contraceptive use to be safe, especially relative to pregnancy. And then I would take some time to, ask her about any birth control myths she may have heard, or if she has any questions about birth control use. And then also take the opportunity to bring up non-hormonal methods that might be of interest, like the copper IUD.
Birth control myths? What are some of the ones you've most commonly heard?
Wow, there are so many myths that we hear, but I'll just cover a few. So number one, birth control is not an abortifacient. It primarily works by making the uterus a hostile environment to sperm and preventing ovulation. Number two, hormonal contraception does not cause cancer. Using a birth control pill actually decreases the risk for several cancers, including uterine, ovarian, and colorectal cancers, but may slightly increase the risk of breast and cervical cancers over time. And thirdly, it's okay not to have a monthly withdrawal bleed. With some contraceptive methods, you may actually stop having a period altogether while you're using them, and that's safe and completely normal.
Thank you, doctor. Let me ask you to continue walking us through your initial encounter with this patient.
Yeah, so next we want to counsel the patient about the importance of using condoms in addition to hormonal contraceptives or some other contraceptive method. We want to remind our patients that hormonal contraception use does not protect against sexually transmitted infections. And for example, that is especially important given the risks and rising cases of congenital syphilis. We then want to ask the patient about their current sexual partners and whether or not their partners are aware of the patient's HIV status. For partners who are HIV negative, we want to make sure the patient is aware that those partners can be offered PrEP or pre-exposure prophylaxis. And we would discuss that pre-exposure prophylaxis, if taken correctly, is nearly 100% effective at preventing HIV transmission to the partner. And in our particular case, this patient is at risk for transmission because her viral load is elevated to 2,000 copies per mil. But that it would still be important to use a barrier contraceptive because the hormonal contraceptive or PrEP would not prevent the transmission of other sexually transmitted infections. And then in the case that the patient was thinking or considering about pregnancy in the near future, we would talk about what pregnancy care for a person with HIV would look like. And our primary focus in that setting in prenatal care is really around viral suppression and addressing social determinants of health and other factors that affect one's viral suppression.
Pregnancy care for a woman living with HIV. What would that look like, doctor?
Yeah, great question. So ideally, women living with HIV are on antiretroviral therapy and virally suppressed before pregnancy. And if that's true, then prenatal care is very routine and really just focuses on the obstetrics part of things. A lot of times we end up helping our patients with HIV achieve viral suppression as early as possible, or again, helping address any social health determinants that may affect or prevent them from achieving viral suppression. If they don't achieve viral suppression in time, then being in care allows them to hopefully have a cesarean delivery in a timely manner, again, with the intent of reducing perinatal transmission risk, potentially avoiding breast or chest feeding their infant if they're not virally suppressed, and then linking the child to appropriate infectious disease care to follow them after delivery.
Would you counsel this patient differently if she were taking a protease inhibitor-based regimen?
Yes, that's a great question. So the answer is potentially, and it would partly depend on which protease inhibitor she's using, which pharmacologic booster she's using, whether it's cobicistat or ritonavir, and then finally, which hormonal contraceptive she's interested in starting. This would give us an opportunity to review the perinatal guidelines together, specifically the table that goes through drug-drug interactions. So for example, a primary contraindication would be for a drospirenone containing hormonal contraceptive if she were on this boosted PI regimen. The boosted PI regimen isn't something I see a lot of patients on. So, since she's on the TAF FTC dolutegravir, she's really a candidate for whichever contraceptive method she would like to use.
Another question, doctor. Dual contraceptive use. Talk to us about that, if you would, please.
So dual contraceptive use refers to using contraception for pregnancy and sexually transmitted infection prevention. And it's important to counsel patients that both of these aims are not always achieved with just the one method. Especially if somebody has a detectable viral load, they should be using condoms or another barrier contraceptive to prevent HIV and other STI transmission, in addition to whatever they decide to use for contraception. So when used perfectly, condoms are 98% effective at preventing pregnancy, but the reality is that perfection is rarely achieved. So condoms only prevent pregnancies about 87% of the time, but they obviously are more effective at STI prevention. Once the patient with HIV has been on antiretroviral therapy long enough to achieve a suppressed viral load, they may be able to rely on U equals U, or undetectable equals untransmissible, for preventing HIV transmission to their partner, but not necessarily other STIs.
Thank you, doctor. So, one last question on this patient. What would you recommend as her best contraceptive option?
Yes, thanks. So really the answer is whatever the patient will stick with, as long as they don't have contraindications or as long as they would like to prevent pregnancy. Those preferences may be based on whether or not they want a monthly withdrawal bleed, daily, weekly, monthly, or even less frequent dosing, a longer versus a shorter term method, and then potentially if the patient desires immediately versus more delayed pregnancy. It may be worth mentioning that there also may be an effect of oral contraception on newer regimens like the long-acting cabotegravir. This information is based out of one study of 85 cisgender women in the HPTN 077 trial. And the study found that oral contraceptive users had lower peak concentrations of cabotegravir, but there did not seem to be an effect on the time to lower limit of quantification, or the LLOQ, nor were there any differences by oral contraceptive exposure in cabotegravir trough levels or levels of exposure between injections, which appear to be the more important pharmacokinetic determinants of virologic control. So overall, yes, it probably warrants further study, but it didn't appear to have been a clinically significant interaction.
Thank you, Dr. Powell. Our key learning point for this part of our discussion is that all women of reproductive age living with HIV should be offered contraception to help them with their family planning needs. What are the key points you'd want our learners to take back to their practices?
I think the key takeaway here is that there are very few contraindications to using contraceptives in the context of antiretroviral therapy. So HIV providers should feel empowered to discuss these options with their patients. As a reminder, the first-line antiretroviral therapy currently is an INSTI-based regimen, and these regimens have basically no interactions with any of the hormonal contraceptive methods, and that the only drug class with potential problems is protease inhibitors.
Well, thank you, Doctor. And we'll return with Dr. Anna Powell from Johns Hopkins in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to our eHIV review program. We've been speaking with Dr. Anna Powell, Assistant Professor of Gynecology and Obstetrics at the Johns Hopkins University School of Medicine, about the need for HIV care providers to counsel their women patients living with HIV about the importance of contraception as well as their available options. Let's turn now to our second key learning point, focused on menopausal women. Explain why, when appropriate, hormone replacement therapy should be offered for symptomatic menopause to women living with HIV. So, if you would please, Dr. Powell, take us back to the clinic with another patient scenario.
Certainly. Our next patient is a 47-year-old with 3 prior deliveries who presents with a 6-month history of bothersome hot flashes. She stopped having regular menstrual periods 14 months ago. She has a history of well-controlled HIV and is currently taking darunavir, ritonavir with tenofovir alafenamide and emtricitabine. She also has a medical history of well-controlled high blood pressure and a family history of breast cancer, but not in a first-degree relative.
47 years old, 6 months of hot flashes, amenorrhea for more than a year. In your published commentary, you discuss the conflicting literature about the age menopause begins in women living with HIV. My question is, in your clinical opinion, is this woman menopausal, and should she be offered hormone therapy to help alleviate her symptoms?
Yes, so this patient is clinically in menopause because she has not had a period for more than a year. Vasomotor symptoms and early menopause or menopause before 40 are both indications for menopausal hormonal therapy. However, current evidence suggests that this therapy is seldom offered to women living with HIV. So yes, she should definitely be offered hormone therapy to help with her symptoms.
Thank you, doctor. So, how would you initially approach this patient to discuss management of her menopausal symptoms? What do you need to find out?
So generally, when we approach patients for hormone replacement therapy eligibility, we want to assess the duration of their symptoms, the timing of menopause onset, and any potential contraindications. We want to make sure that she's within the first 10 years of menopause. Then we want to calculate her 10-year ASCVD or atherosclerotic cardiovascular disease risk factor score by plugging her numbers into a calculator. And that includes inputting her blood pressure reading, her cholesterol, tobacco use history, whether or not she's diabetic, whether she's on a statin or not. And overall, more research is needed in the field of HIV and menopause, primarily on cardiovascular disease and bone health outcomes, as well as symptom control and strategies to reduce HIV acquisition, encourage testing, and maintain older women in care in order to inform optimal clinical management of menopausal symptoms.
Do any of those findings in this patient reveal outright contraindications to hormone replacement therapy?
No, she doesn't. She doesn't have any outright contraindications to HRT. However, we may need to adjust the dosing of her medications to achieve symptomatic control because of potential interactions with her PI-based regimen.
Why is that? What's going on there?
Estrogen and progestogens are predominantly metabolized in the liver by the cytokine P450-3A4 pathway, and to a lesser extent by pathways in the liver and gut, which are shared by a number of antiretroviral therapy agents. HIV protease inhibitors, among other medications, may exhibit inducing or inhibiting properties on some of these enzymes, with effects on plasma estrogen and progestogen levels. Lower hormone levels may result in a reduced impact on symptom control, and in the case of progesterone, lessen the protective effect against endometrial hyperplasia. So higher hormone levels may be associated with an increased risk of adverse effects. Newer antiretroviral therapy agents like integrase inhibitors or newer NNRTIs like doravirine or rilpivirine have little or no effect on the CYP enzyme pathway and are unlikely to have clinically relevant effects on HRT drug levels. So if no outright contraindications are present, she should be counseled about the risk, benefits, and alternatives to hormone replacement therapy.
Alternatives to hormone replacement therapy. Very briefly, doctor, what would those include?
Yes, so hormone replacement therapy alternatives include non-hormonal options such as antidepressants, which could be the SSRI or SNRI drug class, anticonvulsants like gabapentin, clonidine, which is an antihypertensive medication, as well as newer non-hormonal medications like fezolinetant, which is a neurokinin 3 receptor blocker, or oxybutynin, an anticholinergic agent. Some patients may decide that they don't like the risk profile of hormone replacement therapy and may opt for non-hormone replacement therapy. Another indication for non-hormonal menopausal therapy would be if somebody has a higher cardiovascular disease risk profile, or if they have a contraindication like a history of venous thromboembolic disease, breast cancer, or other hormonally sensitive malignancy, or another contraindication to HRT use.
Would you expect to have to make any dose adjustments to her hormone replacement therapy? Assuming that she opts for it, of course.
Right. If she opts for HRT, I would still start her at the lowest dose of medication and titrate up based on how her symptoms respond, but would have a conversation up front about the potential drug-drug interactions and possible need to increase dosages.
We know that she has a family history of breast cancer, but not in a first-degree relative. What does that mean, and how would you counsel her about her breast cancer risk with menopausal hormone therapy?
So this means that she has a slightly increased risk for breast cancer, but she doesn't have an outright contraindication to hormone replacement therapy. Now, the increased risk for breast cancer was identified in the Women's Health Initiative study from use of medroxyprogesterone acetate. So while her family history doesn't preclude HRT use, she could also consider using micronized oral progesterone, which has a better safety profile regarding breast cancer risk.
And what if she had an elevated 10-year cardiovascular disease risk score?
So the optimal ASCVD 10-year risk score is 5% or less. This would mean that the patient would be a candidate for oral or transdermal therapy. If the ASCVD 10-year risk score is greater than 5% but less than 10%, then she may still be a candidate to use transdermal hormone replacement therapy. And if it's greater than 10%, then I would really encourage that patient to consider non-hormonal options instead. Generally, we don't want to further increase a person's risk of cardiovascular event or stroke while still providing them with management options to help their symptoms.
One more question on this patient, doctor. The idea that HIV may be a risk factor for an earlier transition to menopause. What does the evidence say about that?
So women living with HIV appear to be at higher risk for menstrual irregularities, primary ovarian insufficiency, and early menopause. This may be due to a variety of factors that include HIV disease itself, including having a low CD4 count, more frequent tobacco use, chronic infection, including hepatitis C co-infection, lower estrogen levels, chronic stress response, and metabolic changes that accompany HIV, including weight changes, insulin resistance, or chronic medication use. Menopausal hormonal therapy is also underused in women living with HIV, and we need to keep in mind that this population may especially benefit, particularly in terms of preventing and reversing poor bone mineral density, which can be a side effect of chronic antiretroviral therapy use.
Thank you, Dr. Powell. Our key learning point for this part of our discussion is that menopausal hormone replacement therapy is underused in women living with HIV. What are the key points our listeners should take away from our discussion?
So when considering prescribing hormone replacement therapy for a patient showing signs of menopause, some key things to keep in mind are, number one, to assess the patient's menstrual cycles and ask about their vasomotor symptoms. Number two, assess their candidacy for menopausal hormone therapy use. Number three, offer hormone replacement therapy if they don't have contraindications, or offer non-hormonal options if they do have contraindications. And lastly, to keep in mind that there are infrequent drug-drug interactions, and the benefits of treating symptomatic women living with HIV may include improved bone health and an improved cardiovascular disease risk profile.
From the Johns Hopkins University School of Medicine, Dr. Anna Powell, thank you for sharing your knowledge and expertise in today's eHIV review program.
Thank you so much for inviting me.
For eHIV Review, I'm Bob Busker.